morning. My name is Dr. Krista Damann. I'm a neuropsychologist at Rochester Regional, and we're here today to talk about concussions.
And I'm Dr. Daniel Day. I'm a sports medicine physician with Rochester Regional. I work in the concussion clinic. And as you've probably noticed, there's a news article that came out and has been in the paper and in the media regarding CTE. So this is a study that just came out. It was just published within the news and in the newspapers. And what it really says is, or why it's so getting so much press, is within the NFL, they found that 110 out of 111 people that donated their brains were diagnosed with CTE. So if we go through the initial study, it had 200 plus people in it, and it's really one of those things that is clinically relevant because it's important with our sports. So we're going to go into what an acute concussion is, we're going to go into what CTE is, and hopefully it will shed some light on this topic.
Great, yeah. So it's always important to go back to the basics when we think about concussion. Thankfully, we know a lot more about concussion than we used to, but still, people need to know the details. If I can boil it down to the most simple definition of concussion, there's two things we need, okay? One of which is sufficient force to the head or neck. The second is an alteration of consciousness. So when we think about sufficient force, there's been some really great helmet studies in the football field that gives us an indication of how much force is necessary for the average person to sustain a concussion. And that threshold appears to be about 100 G. Now, to most of us, that doesn't really mean anything. So we kind of want to boil that down to something more tangible. We can think about if you're driving a car going about 25 miles an hour and you run into a brick wall, and you either have a whiplash injury or your head hits the steering wheel or the dashboard. That's roughly about 100 G in terms of force, okay? Now, we used to think, before we knew as much as we know now, that having a concussion meant a total loss of consciousness, meaning you are knocked out cold. And we know that's just not true. So an alteration of consciousness really involves things like feeling a little bit dazed, disoriented, and confused. There's also something you can experience, I like to call it Swiss cheese memory, okay? So there's just these gaps in your memory like a piece of Swiss cheese where you might be thinking back after the concussion and you can't think of little things that happen and people remind you of them. So after you have these two qualifying events, sufficient force and alteration of consciousness, we oftentimes see a number of physical symptoms that lead us to believe also that we're having concussion. And these types of symptoms tend to be things like head pain or headache, nausea, dizziness, imbalance, sleep disturbance, and the list kind of goes on and on, also like sensitivity to noise and light and those sorts of things. We can also see some cognitive changes associated with concussion, and that can include problems with attention or focus, cognitive slowing, so your thoughts just seem slow and harder to put them together, and then short-term memory loss can be a symptom. And so these are all kind of the acute symptoms that we're looking for. And then I'll kind of pass things over to Dr. Day to talk about how we manage these acute symptoms.
Yeah, and I think the good thing is we've actually gotten really good at treating the acute concussions because now there's the awareness, there's the recognition, we can actually get the diagnosis now, and if we have the diagnosis, then we can treat it. And at our concussion center, we have a whole team of people, and we have a lot of resources that we can use to treat concussions. So the first thing is the recognition. So we diagnose concussion and they come in and they're acutely symptomatic. So the first thing we want to do is try to get their symptoms improved. We can do things like vestibular therapy. So often that can improve their vestibular dysfunction, which can improve their reading and their overall symptoms. We put them on a return to learn program. We put them on a return to play program. And if we can get their symptoms improved and we get them through return to learn or return to work, then we can get people back to their normal lives and after acute concussion. And the good thing is most acute symptoms really resolve after the first 1 to 2 weeks, and then we may need additional services for that other 10 to 20%. And that's where people like Krista come into play. Do we need neuropsychology? Do we need neurology for ongoing headaches? So those are some of the resources that we can use after those acute symptoms actually end up coming down.
Sure.
So we can get often cleared from the acute concussion, and then sometimes we're handing over for some of the sequelae from the acute concussions and having them see people like Krista, or having them see neurology for the headaches. Do you want to go into kind of some of those things with those sequelae?
Sure. So sometimes we see some chronic symptoms, meaning people aren't getting better at the same rate that most people might after a concussion. And there's a lot of speculation in the research about why that might be. Sometimes we have certain risk factors that predispose us to having a harder time with recovery. So if we boil down a concussion to an adverse event, it's basically a stressor in life, right? It kind of knocks you off your game. You're not able to maybe go to work or play your sports or do things you would normally want to do. And that in and of itself can be stressful. And all of us have tendencies to handle stress in certain ways, right? Some more healthy than others. And one of the things when we have more knowledge about concussion is sometimes we see people taking it a step too far, right? Getting a little bit paranoid or overly anxious about their symptoms and focusing on them way too much, right? So if I keep focusing on the problem grows, psychologically grows for me.
And plus we have them out of the activities that they like to do. So if we can really diagnose that acute concussion, resolve the symptoms, and get them back to the things they want to do, and then augment it with some of the psychosocial things that you guys address, we really have much better outcomes when that
That's absolutely true. One of the things we tend to see is that the emotional factors, whether it be depression, anxiety, those sorts of things tend to develop over time. It's not always an instant thing for folks. And so it's really important for us to be monitoring those things and addressing them and being as proactive as possible to prevent that, because quite honestly, I see a lot of people in my clinical practice who have actually resolved their concussion, but they have lingering depression or anxiety that's making them not be able to move on with life, and we really need to address that aggressively.
Yep. And now, now that we have these kind of acute treatments, we can get them plugged into the services they need and get them back to what they love to do. Now articles like this now come out, and what are the long-term problems with concussions or repetitive head injuries? And that's really the question on everybody's mind at this point.
Absolutely.
So this is, and the research is just really starting to come out now, and we don't have a lot of the answers, but articles like this one, really strike fear in a lot of parents, especially when they're thinking about letting their kids play sports. So we have to have good answers as far as, what do we tell parents? How do we, what do we need to do to go forward? How do we get better information? So this is the tip of the iceberg, this article.
Yeah.
I don't know if you want to talk a little bit about the article.
I think we should talk just a little bit about CTE. So I think most people have heard that acronym, but it stands for chronic traumatic encephalopathy. And so what the article we're referencing is looking at pathology in the brain. So all the people in this study were dead. And we cut into their brains and we looked to see if they had high tau protein. And many of them did, okay? And so that's diagnostic for CTE. Unfortunately, we don't have any way to, reliably diagnose CTE while you're alive. Just like many other neurodegenerative conditions, it's autopsy that helps us to confirm that.
We may be getting better at, or getting closer to being able to do that. Like in this study, most people kind of assumed that they had CT, which is why they were donating their brains.
Yes.
But some of the research studies going on with some of the more advanced imaging, maybe we will have a way to actually formally diagnose this in living people. And I think that's going to be key in getting a lot more information. Absolutely.
One of the things I just feel really importantly I need to say about the article, if any of you ever look at it, is there's a huge selection bias. Meaning it seemed like 99% of the people in the study that played professional football had CTE. That's because they all knew they were having symptoms. So they were really good at detecting, hey, something is not right with me. I'm experiencing changes in my mood. I'm having impulsivity, I'm having aggression.
Families noticing.
Yeah, mood swings. And so there's a behavioral variant, and there's also cognitive changes for some folks. And then some of them have a progressive cognitive decline. So those are the things we're kind of looking for in CTE. And so I'm thankful that we know enough about it that people are being able to identify for themselves that things aren't right. But what this study is really lacking is a control group, a comparison group of people who played football at a professional level but weren't experiencing all those symptoms, right? Because we don't know how many hits is too many. We also don't know if it's an actual concussion, repetitive concussions, or if it's subconcussive blows to the head, just a lot of cumulative hits over the years that causes CTE. And these are questions that we really are going to need to answer so we can help manage the risk better for football players and other people who like to play direct contact sports.
And we have to compare it to general population too.
Absolutely.
So, what were these football players doing in their spare time? Were they risk takers? Were they, racing cars and jumping out of planes and having more head injuries that way? So if we can compare it to general population, then we get better numbers.
That's a great point, Dr. Day. So one of the things I was noticing is that can there be factors that predispose certain people to these conditions to developing later in life? If they have mental illness running in their family, for example, are they at increased risk? Or history of substance abuse? So we don't know if there are also protective factors. Are there certain things that people have that protect them so they won't develop CTE even if they have repetitive head trauma? And these are all things that we need more research to help us clarify.
Yep, and if we can diagnose this more efficiently, then we can get bigger studies. I think ultimately it's going to be better if we can lay out the risk. So if we say your risk of playing high school football leads to this % of brain injury, then we can make more informed decisions rather than making decisions based on fear.
That's a great point. Not to interrupt, but I wanted to mention that the study too really underrepresents people who play at youth and high school levels. Okay, so the majority of people's brains that were donated for this study who thought they had CTE played at the collegiate and the professional levels. So we can't necessarily say if you're a high school athlete and you've had 2 or 3 concussions that you're going to be at increased risk for CTE. We just don't have that data.
Right. So let's say, Krista, you have a patient coming in and they've had multiple head injuries and maybe they're considering returning to sport. Maybe they're of age where they don't need parent consent, or maybe they're underage. What are you telling these people as far as what you recommend? That's
a great question. So I always think, we don't want to pass the buck to someone else, so we have to make these sorts of decisions even though they're hard. What I typically tell people is there's really 2 options. There's prevention and there's managing risk. So prevention is not going back to sport, particularly sports that have a lot of direct contact involved. A lot of times I can recommend that, but I can't force someone not to return to play. So I think where we're at as a field in general is really trying to manage risk. That's why we have return to play protocols that we used to never have. And there's a lot more success with those. I do feel that people need to follow those more closely. I hear a lot of athletes who might minimize symptoms because they want to return to play, or parents even encouraging their children to go back to play before they should. Even if an athlete is returned for play or cleared to return, that doesn't mean they necessarily should, because they do have increased risk. And one of the other things that I'm really kind of big into these days is trying to think of a diversion program. Can there be increased opportunities for concussed athletes to go back to sports, but sports that have less inherent risk? So an example I was just talking about was a football player, perhaps a running back who's taken a number of hits and had some concussions. Can we transition that person, that athlete, to playing track and field, where they can still be competitive in sport, they can still train, they can still be part of a team and experience all the benefits of sport while reducing their risk of repetitive concussions?
Yeah, and this is becoming really the question, right? So I can't tell you how many parents come in, just even, family and friends, as we kind of run into each other at gatherings, would you let your kid play? Or what should I do with 8-year-old Johnny here and who wants to play Pee Wee football? So it's really a tough question to answer at this point because we don't have the full data. So it becomes that risk-benefit decision. So that's the initial kind of, do we let them play in the first place? And then let's say they've had a handful of concussions, and we're looking at the big picture. Maybe there is some psychosocial stuff going on too. You know, what's the risk of returning to a higher contact sport versus what's the risk of returning to, you know, something like cross country? Because there's certainly benefit to sport. So it'd be unfortunate if, you know, we lose that benefit of sport because the risks are so high. So hopefully we're able to get better numbers, better data, and then we can change the game enough to reduce some of those risks that we find, and we keep people active and healthy and playing sports. I mean, I think that's really the bottom line, and hopefully we get some more of this information as time goes on, whether it's 2 years or 5 years. I mean, this is actually a good sign that we're getting these literature and these articles coming out, and this debate is ongoing. I'm sure you see it in the papers, you see it. I was listening to Mike and Mike this morning, and they're talking about it, and we had 2 football players on that show, one saying I'd go back and do it all over again, the other saying, I don't know, I might actually reconsider, and I'm not going to let my, you know, my now 4-year-old consider playing. So, you know, it's quite the hot topic right now in with sport and
Definitely
concussions.
is, yeah. And all of us can relate. I mean, we all have brains, and you don't have to play a sport to sustain a concussion, right? And that's one of the strengths of our concussion program here at Rochester Regional. We not only work with concussed athletes, but we also work with people who've had a concussion at work, falling at work or outside your driveway. It's Rochester, there's ice in the winter, people slip and fall. So your brain doesn't know if you had a concussion because you were in a car accident or you took a hit on the football field. And so we provide really great services. So I'm excited to be part of this exciting and kind of the new involvements and developments in the field. I'm really excited to be part of it, particularly here at Rochester Regional.
Yeah, definitely happy with the team that we've built. Think that you know, the services that we're really able to get people into now have really improved outcomes as far as the acute treatment, and now we're really starting to dive into some of the chronic stuff. So we, you know, have people that are coming in that, you know, they're six months, a year out, and they've had personality changes, and you know, we're really implementing, you know, how do we treat this now? Like, these are real problems and real people now. So we have to have a treatment plan based on the best literature that we have. So I think that, you know, thanks for tuning in. Hopefully we can have some more of these conversations as more articles and literature comes out. I'm really excited to see what comes out over the next few years, because I think our tunes will be changing. So we'll have to kind of adapt and see how things grow. But really appreciate you guys tuning in. If you have any questions or anything, we'd be happy to answer those. Any last thoughts, Krista?
No, I just again thank the viewers for watching, and spread the word. I mean, education is key to make informed decisions.